Thank you very much. I am by names of Dr. Ssentongo Saadick. I'm from Uganda. I work with Teso, and I'll be presenting a paper on TB titled Improving TB Case Identification Through Intensive Community Door-to-Door TB Screening in Teso region, northeastern Uganda. One thing we need to understand about TB before COVID, of course, TB was the big boy in the house. It was killing more people. Right now, it's second only to COVID, but still, we can see that, of course, we have done so many investments in COVID, but TB is still lagging behind. As we are all aware, as of the global report of WHO, last year we had over 10 million people that were diagnosed with TB, and of those, only 6.4 were able to get treatment. So that leaves a balance of around 4 million people who were either not diagnosed or not treated for TB. And since this is an HIV conference, we all know that TB is the leading cause of death in HIV. In the HIV programming, we have made progress because the target of 2018 to 2022, we are supposed to initiate around 6 million people on TPT, but I think we overperformed. We had over 10 million people, so that's around 103% initiation of TPT. So we need to clap for ourselves for that progress. So basically, this is the background of where we come from Uganda. Teso is one of the regions we have in Uganda. It is in the eastern part of Uganda with 10 districts and 1 city. And it has around 2.5 million people on the area of around 13 kilometers. 13,000 kilometers. And it has an HIV prevalence of around 4.2%, with a community viral suppression of 77.2 among the adults aged above 15. Currently, Teso is implementing a project there, which is a CDC-supported project. And in that region, we have around 111 health facilities with over 1,672 TB cases that are diagnosed per year. So as we continue, I've talked about, this is just a background of this paper. Uganda, we are unlucky or lucky, either two. We are among the 30 high-burden TB countries, and still among the 20 countries that contributed to 83% of the missing TB cases in the world. That is according to the global report of TB of last year. And on top of that, still, globally, we all know in 2020, there was a fall in the TB cases diagnosed by 18%, whereby we moved from 7.12% to 5.83%. This one is the newly diagnosed. As we all know, TB has categories: the newly diagnosed, the relapses, and the failure. So for the newly diagnosed, globally, when COVID came in, we moved from around 7.12 million to 5.83 million. And for the case of Uganda, we also fell by around 16%, with 13,179 TB cases that were expected to be diagnosed, not being diagnosed. So this was as a result of, in Uganda and Teso, the different COVID pandemic restrictions which are put on movement, making the health workers and the clients not be able to access the health facilities. Of course, we all know COVID and TB tended to have similar symptoms. So this stigma which was within the population and the community resulted into people or our clients not seeking health services, and some health workers fearing to screen for TB, which also resulted in the fall in TB even in Teso for around 44%. So in our settings in Teso region, northeastern Uganda, we have implemented several interventions to ensure that we find so many TB cases. Despite the different interventions done, the outputs from the community arm of TB case finding was not very clear. So that's why we implemented this approach of the door-to-door, so that we can easily understand how can the community door-to-door TB screening clearly contribute on finding many TB cases, with support with CDC and Ministry of Health Uganda. So I've talked about despite the different interventions in the region, we still had missing TB cases. You saw in our background that around 44 TB cases missed, and not all people with TB come to the facility. As we all know, some people with TB, by the time they present, they are in late stage, and that explains the 50% death of TB globally. So therefore, this study is very critical in bringing in light the high-yielding approaches in finding the TB cases through using the community health workers to conduct the door-to-door TB screening in Uganda. So the broad objective was to describe how intensive community door-to-door TB screening improved TB case identification in Teso region, and also the specific objectives were to engage the community health workers per village and health workers to improve the TB case finding, to create awareness in the population on TB prevention and treatment, and strengthen community and facilitate linkage for sustained treatment outcomes. So this is what was done. Of course, Teso Soroti Regional Project, at the onset of this activity, we are able to engage the district leadership, and from the district leadership, we are able to train the community health workers. The community health workers, these are volunteers, or these are people with basic education that are part of the community structures of the country. They are able to read and write, and they have basic knowledge on health services. So we invite them, and they are all attached to the different villages in the Ugandan communities. So we invited them and trained them on TB case finding approaches, TB screening, and also the different TB health messages. After that, we provided them with the sputum mags, gloves, masks, and everything, and the IEC materials that were in a local language, and they went to conduct TB screening in the communities for 4 days. The sputum samples that were collected were taken to the facilities where they are picked and taken to hubs for testing using GeneXpert. These members conducted TB screening for 4 days in their villages, and the test results were returned to the facility and taken. We also conducted community hotspot screening. As we know, we have the household contacts and the close contacts of TB, which are also at high risk of getting TB. From the picture, you can see the right one, the upper one, where that was an engagement at one of the facilities of the community health workers, and down that was a hotspot based on our data analysis where we are getting so many TB cases. So in this infograph, you can also see up there, I talked about the engagement of the community leadership. Given it was tough times, you needed the leaders before you proceed going to the community. And down there is a picture of door-to-door TB screening in Bukedia district, which is one of the district we support. And the other side, there with the motorcycle, that was the DTLS, that is the district supervisor of TB programming, moving in the villages to ensure that the activity is being done timely and effectively. So these were the results. Of course, in March and September, we are able to approach or to screen and in around 1,780 households. Those are households within those communities. And we are able to reach out to 763,424 individuals in those households we are screened for TB. Of those we are able to presume 6%, which was 43,547. As we all know, with the resources we have in the country, we cannot, of course, speak sputum from everyone. So we screened using the WHO symptom tool, which guided us, and of those that were presumed, we are able to pick the samples. Of those that were presumed, 91% of those were able to give us the samples, which were taken to the hub for the testing. So that was 91%, which was a figure corresponding to 39,000. So of those, overall, we are able to diagnose 548 TB cases. These are people who would have missed because they are in their home comfortable and they are saying, I have cough, I take Panadol, and they move on. So we are able to get 548 TB cases. That was 276 in Jan, March, and 272 in July, September. So you can see, in comparison, this is a comparison, a graph showing the TB cases identified. You see in Jan, March, we had 815. That is facility and community. And of those, community contributed 270 TB cases, 76. So these were people in their homes, and they didn't come to the facility. We found them in their homes, over 276. And then that was a contribution of 34%. So in that region, 34% TB cases were within the community, within that quarter. Then in the second quarter, that was in July, September, 272. Out of the 962 diagnosed. So that approach contributed 28%. These are not numbers. These are individuals. These are mothers and parents that would have missed and they would have succumbed to TB if we did not move out to those homes and try to screen them. So this is a graph showing the possibility and the beautifulness of this. I don't know whether that's correct English. The beautifulness of this approach. In October, December 2021, the TB case notification was 72%. With this approach, when we implemented it with support, we moved to 91% of the expected TB cases. In April, June, we did not implement this approach. But in July, September, we implemented again this approach. So on the right, you see those graphs with the green colors. We implemented it in Jan, March, and also in July, September. In Jan, March, we moved from 72 to 91%. In July, September, we moved from 87 to 107%. So the second approach, because we had already done community sensitization, people were aware about, so people were open. No stigma, they came on board, and we were able to diagnose all the expected TB cases, achieving 107%. So the lessons learned from this approach, one, was that community door-to-door TB screening with the skilled community health workers equipped with the WHO 4-symptom screening tool, such that you are very focused to ensure that you get those clients in time. Supported and helped in increasing the TB case notification in Teso region, supporting with finding the missed TB cases across the supported 10 districts. Two, engaging the district and community leadership, increase the responsiveness of the community members towards finding missing TB cases. As we all know, if we are to sustain vis-a-vis the finances for all of us who have been in the TB programming and HIV programming, we know the pocket for TB is not so much big vis-a-vis the different new innovations coming up. So engaging and working with the districts to own this activity made it very easy for us to go to the communities, engage them, and screen for TB to ensure that we are able to reach out to these mothers with less resistance. This approach is high yielding, as we have seen, contributing to 34%, 28%, and supporting and enabling a region which was at 72% before this approach to reaching 103%, making sure that we are able to find all these missing TB cases. And therefore, in challenges with enough in settings with enough resources, it can be utilized. However, it's key to note, I put a note down there, that this approach is high yielding, but for sustainability, it requires effective partnership from the Ministry of Health, from the IPs, and also support from the development partners, that is CDC and USAID. Because those costs incurred in moving samples, running those so many samples, because if you are going to implement it, if you are going to collect samples from over 15 districts, you can just think about how many samples you run. And remember, you are not only using those machines for what? TB. You are using the same machines for multiplex testing, you are using them for viral load in some facilities, cervical cancer for HPV, and all those other tests. So if you are to do this approach, you need to get support from MOH, so that they engage the districts, and also support from the IPs, the implementing partners in the different region, and also approvals from CDC, because sometimes you might need some funds to run these approaches. Thank you very much. I conclude by thanking Ministry of Health Uganda for the support, PEPFAR for the continued support to Uganda and also Teso region, CDC, the district teams, the facility staff, and the community health workers that supported us. Teso Soroti Regional Project Management, I have our manager here, the overall boss of ours, Dr. Susan, who supported us to ensure that this thing was done. And also I esteemed clients to allow us an opening their doors to screen them for TB. Thank you very much. May God bless you.